Respected chairpersons, my friends, colleagues, and seniors in the audience, a very good afternoon. First of all, I must thank the organizing committee to invite me here to talk at such a wonderful conference. Now, my talk, which is on sexuality and cancer, is actually a pretty much of an offbeat subject for our Indian population, but is gaining more and more importance as time goes by. Uh, as treatment for cancer is getting better and better, our patients are surviving a lot more for many more years with cancer, and even a lot of them are getting cured. And therefore, quality of life issues are becoming more and more important. Sexual intimacy is a very central part of quality of life for all of us. And therefore, this talk becomes a little more relevant as time goes by. Um, Sexual intimacy is not just a bodily function. It's a lot of, it's in human beings, it's a mind, it's a mind game. It's only when the mind, body, and the soul are at one that, one person gets complete sexual fulfillment. So when you talk about a cancer patient, typically speaking, cancer patients have been deemed as severely ill. And we know that because sexual function is an important factor for quality of life. Sexuality is also affected by the disease, the type of cancer, the extent of cancer. It's also affected by the type of treatment you give, whether it's cancer, it's radiation, it's chemotherapy, and more importantly, it's the individual's psychological responses, the individual's coping mechanism, the kind of support structure they have, the kind of psychosocial, religious, cultural upbringing that they have. So everything actually culminates in, sort of understanding how a person's sexuality is. Uh, Okay, defining sexuality. I'm just going to say this very fast. Human sexuality is a kind of attitude, experience, expression driven by common intuitive tendency for reproduction, which is highly individualized through control by superior psychocognitive centers and so on. It's a very Sashi Tharoorish kind of a definition, right? So people don't really understand what is happening. But what this basically means is what I said earlier, that sexuality is a combination of what happens to the body. It's not just a somatic function, it's where your mind is also. And as I said again, I repeat, in India, it's based on your culture, your ethos, and religion. So everything sort of culminates into what is sexuality. The WHO says that it's the central aspect of being human, encompassing sex, gender, sexual orientation, which is also becoming more and more important in today's day and age, intimacy, and of course reproduction. So let's look at the mechanism. We all know this, but I'll just run by it very fast. It's first of all, there needs to be a sexual desire. Then there is arousal, where there's erection in males and lubrication in females. And then it culminates into penetrative or non-penetrative intercourse, orgasm and ejaculation in males, and culmination in females. And finally, there's resolution. So cancer and its treatment can actually affect each and every aspect of this mechanism. I'll give you an example. For desire and arousal issues, patients with cancer have somatic pain, they are fatigued due to cancer therapy, so they're generally tired. They may have hypothalamo-pituitary gonadal dysregulation, say hormonal treatment. Men with prostate cancer are on estrogen-based hormones or anti-testosterone hormones, so they don't have the desire. Surgical castration, men may have an orchiectomy. So it all sort of reduces that desire. What about women? Women who have had a radical hysterectomy or whose ovaries have been removed, their estrogen levels are low, their desires are low. If they've had radiation, there is vaginal fibrosis, this pelvic fibrosis. So all this leads to insensitivity. Symptomatic treatment. If somebody is consistently unwell, say on chemotherapy, they're vomiting, they've got diarrhea, the last thing on your mind at that point of time is to have intercourse. So they just don't feel good about it, right? So, and then there are many other things like morphine can lower testosterone levels, sleep medication disturbs nocturnal erections. So there are a lot of mechanisms that interfere with your desire and arousal issues. What about erectile dysfunction or lubrication in females? As we just mentioned, it's again, hormones can sort of play havoc in this area. Surgery and nerve damage, radical prostatectomy, retroperitoneal lymphadenectomy, all these are procedures that destroy the pelvic splanchnic nerves or the nervi urgentis that are very important for, say, erection and ejaculation. All this can lead to anejaculation, retrograde ejaculation. It can be a quagmire of problems. In women, as we talked about it, there can be vaginal fibrosis, there's dyspareunia, there's loss of lubrication. All sorts of things can go wrong here. So, and at the back of all this is the psychological mechanisms. A person with cancer accepting and coping with a life-threatening illness. Generally, these patients tend to be depressed. Oh my God, I've got an illness. What's going to happen about the future? What's going to happen to my children? What's going to happen later on? They are overwhelmed. So in this kind of a background, sexual intimacy again is the last thing that comes onto their minds. Financial issues, which is so important in our country. Oh my God, how am I going to fund my chemotherapy and my radiation and so on and so forth? Another big issue is body image. Women who've had a mastectomy, or men with partial or total penectomy or orchiectomy, they have a distorted body image about themselves. They again don't feel good. Radical abdominal procedures that we do. I mean, say somebody with colon cancer has a colostomy, somebody with muscle invasive bladder cancer has an ileostomy, which we heard some time back. There are stomas. It's a very body image disfiguring kind of a concept. Loss of hair in chemotherapy, and generally these people have loss of self-esteem. There's something known as partner paradox, which is very, very interesting. So let's assume you have a couple. One has cancer, one does not have cancer. So the person who does not have cancer feels that, oh my God, my spouse has got cancer. What if I try and get intimate with him or her? They might get hurt. So let me stay away. Whereas the person with cancer feels, my spouse is not coming near me. What's wrong with him or her? The exact opposite situation can happen, where the person who does not have cancer tries to get intimate with the person with cancer, and the person with cancer feels, oh, he's or she's just coming near me because they have pity on me. I've got cancer and they're pitying me. So it's a partner paradox. Nobody knows what to do. So these are very complex psychological mechanisms, and to get over that, it's a difficult job. So these are some of the photographs that we've already seen before. The one on your top left, one with two stomas, like somebody who's had an exenterative procedures. The one on that side tells you what a partial penectomy looks like, a mastectomy, a total penectomy. So these are completely disfiguring surgeries. So these patients are bound to have a low sexual self-esteem. So again, sexual impairment in cancer is multidimensional, multifactorial. Some consider it as an abrupt psychological trauma. In fact, it's even listed down as a PTSD, like a post-traumatic stress disorder. So the important point is, how do you get around all this? The important thing is to start talking about sex as early as possible in the treatment of patients with cancer. And when do you suspect hidden sexual problems? Obviously, they can happen to all patients with all types of cancers, but more so when the external and the internal genitalia are concerned. It's important to remember that even when patients are deemed cured, the quality of life can suffer after 3 months, 6 months, 9 months. And classic example is cervical cancer, where radiation cures them, but causes so much of fibrosis that they just can't have intercourse. So, it's at every follow-up, we as oncophysicians and oncosurgeons shouldn't just look at the fact that, oh, you're cancer-free, go home, you're happy. You need to understand the quality of life issues also. So how do you go about unmasking the sexual problem? The most important thing here is to have an integrated team, a team that has sexologists, a therapist, specialized nurses. They have to be integral to a team of medical oncologists, surgeons, and radiation specialists. It's important for everybody involved in the care of cancer patients to understand that this is a problem and this has to be dealt with. In fact, it's our job to bring out the topic and open a conversation, more so in an Indian context. No Indian patient is going to come and tell you, oh my God, I'm not having sex at home. It's up to us to sort of try and get that conversation about. You can say lots of things. You can talk about a third person. You can say many patients have difficulties with sexual contact. How is this for you? Or I'm currently treating a patient with so-and-so problems. Do you also face similar kind of a situation? So it's important for us to initiate the conversation and the contact. And then there are a whole load of questions that you can ask. I'm not really going to go into them, but it's important to understand that the partner also needs to be involved in all these processes. As I said, everyone involved in the care should be aware of the problems. The patient actually decides when he or she is going to come out with these problems. The patient also decides when they want their partner to be involved. That's also important. You can't involve the partner anytime you want. But it's up to us to pave the way. It's up to us to start opening conversations and get a headway here. And it's important for all of us in the team to be trained for it. So we need to be knowledgeable, we need to be proactive, at the same time empathetic, at the same time professional, and we need to recognize these intimacy issues about the patients. And obviously refer them on to the psychologist or the psychotherapist as required. So there are a large number of tools that have come around that help us to recognize these hidden problems. One is the PROMISE tool, which is a patient-reported outcome measurement information system. This is like it's a 3-layered questionnaire that actually gives you an insight into these issues. Then for women specific, there's an ASEX tool, there's an FSFI tool. For men, there's a SHIM tool. So there are lots of questionnaires that you can ask them, and you get an idea not only about the sexual intimacy problems, but what are they? Are they more somatic? Are they more psychological? And so on and so forth. So while dealing with these problems, the model that is followed commonly is known as the PLICIT model, where P stands for permission. So first you ask permission with the patient to talk about it and get started speaking about it. Next is you provide patients with limited information about normal physiology and how their physiology has changed because of cancer and its treatment. And then you talk about specific suggestions to them based on a full assessment, whether they need they need anatomical correction in the form of surgery, whether they need medication, or they need cognitive behavior therapy, and ultimately you actually come down to doing those intensive therapy. A couple of small issues that I need to highlight here before I end my talk in the end. Terminally ill patients, that's an important group of patients. Quality of life matters for them also. These patients also need an intense relationship with their partners. Here, intimacy is more important than the actual act of sex. So this is important for us to realize. It's important to address these issues with the partner right at the beginning in the treatment phase, that this can happen and you need to be prepared for this. So that's one important thing to keep in mind, terminally ill patients. Another huge chunk of individuals that we need to know about is the adolescents and young adults who get cancer. More often than not, these people are going to get cured and they're going to have a long life afterwards. And sexual problems and intimacy problems are going to be, they're going to be huge with this population. So we have to be very careful. In fact, there's a lot of work being done on the AYA, the adolescents and young adults. And it's interesting to read also about these issues. So for instance, there was this one sort of a trial or a study which is called the HOPE, Health Outcomes and Personal Experiences, where 50% of these young adults and adolescents had sexual problems. It's that age group that starts becoming sexually active. They have other issues like fertility conservation, contraception, STIs. So all that needs to be considered. Generally what happens is, it's an important concept to understand, there's delayed intimacy milestones. So you have 16, 17, 18, 19-year-old in normal society, go to college or high schools, they hang around with their friends, there's a little bit of flirting with the opposite sex, and that's kind of a milestone in their growth towards intimacy. These people who've got cancer, they miss out on those 2-3 years of their life. They are in radiotherapy, or they're in chemotherapy, they're in rehab, all sorts of things. So these milestones are delayed, and it's important to understand these issues so that they need counseling and help to get over this later on. Obviously, today, as I said earlier, the LGBTQ cancer patients and survivors also have their own set of issues, and that's also coming up in a big way in a lot of trials and studies. So ideally, if you have a couple where one has cancer, they need to be seen in an interdisciplinary network where you need a gynecologist for the female patient, an andrologist for the male patient, with a sexologist, a psychologist, a psychotherapist. All of them need to work together with the oncological surgeon, the medical oncologist, and the general practitioners. So only in such a multidisciplinary network can you get the best results out of these people. The idea is to form or get practical solutions and address irreversible issues like stomas and nerve damage. How do you get around that and yet the couple can get intimate? So coping strategies have to be devised, which are easy for them, but sometimes it takes time and effort to get these things going. So for males, some of the things that can be done is hormonal treatment with testosterone or PDE5I, drugs like Viagra and many others that have come around, vacuum pump elastic bands, there are intracavernous injections, there are medical urethral systems, there are all sorts of things that are there. So it's important to determine what's best for whichever patient. If you look at women, there are special lingerie for patients with stoma and for breast. If you look at this photograph here, she's wearing a nice reddish stoma bag here. Or the lady who's lying down there, you can see a central incision right in the middle, just next to the black stoma bag. So, these kind of things help build up a body esteem for patients. Also for women, vaginal lubricators, dilators, pelvic floor exercises. There are some new drugs like flebanerin and bremelanotide. These are drugs that enhance arousal. These are complicated drugs that act on the serotonin receptors in the brain. So all sorts of things are available. It's just up to us as a team to decide what can best help our patients. This actually, it's very difficult to read what's given here, but this is a paper that was published in the JCO by the ASCO in 2018, and that sort of summarizes where we currently stand with respect to sexuality and our cancer patients and what we can do for them. So anybody who's interested in this can actually read up, and there's a lot of more reading material that's available. And in fact, it's good reading material. It's simple text, it's simple language, and it's fun to read this also. So I won't take much of your time. Thank you.